Welcome to North of 60. I'm Heidi Schweighofer. Today we're going to talk about our aching feet. My guest is Dr. Richard Rasper, a board-certified podiatrist with the United Health Network. Dr. Rasper has offices both here in Hudson and in Talmadge. Thank you for being here.
You're welcome.
I'm glad I got that through all of that.
Yes.
Dr. Rasper, I want you to start by telling us a little bit about the most common problems that you see in people over the age of 60 with their feet.
Yeah, you know, there's basically a couple of categories. There's some orthopedic problems, and then there's some dermatologic problems, and some systemic problems that really have an impact on people's feet. So 3 orthopedic problems that are common. The first one would be heel pain and plantar fasciitis.
Oh, I've had that.
Oh, have you?
Oh my gosh, that is painful. Now tell me what happens though with us to get that.
Well, you know, as we get older, there's a band of tissue. It attaches from the heel here to the ball of the foot, and it gets too tight. So at night when you sleep, it really tightens up. So when you start to walk, your foot wants to stretch, but this band won't stretch, so you get micro tears right here on the heel. And that produces pain, especially when you get up in the morning.
Yes.
Or if you sit down for 20 minutes or more and it hurts. And so it can be very disabling, very difficult problem.
Why does it tighten? Is it just an aging thing?
Yeah.
Oh,
Very few people under 20 have this problem. So, yeah. It's just like a lot of things.
Yeah,
you know.
I know.
Yeah.
So what do we do about it?
Well, 3 things. Proper stretching is important. So we have some specific stretching exercises I recommend usually at the office. And then arch support. And then we have to get rid of the inflammation in the heel. So depending on the severity, ice can help, maybe some oral anti-inflammatories, and often a shot of cortisone helps quite a bit.
Okay, right in the heel.
Yeah, you should go from the side and get it in there. It's kind of like a big aspirin right in the area. It decreases the inflammation.
Okay.
Yeah.
Do people still wear boots and all of that sort of stuff? To sleep? And
the night splint. Those can be helpful, but they're a pain in the neck.
It's very hard to sleep with them.
Yeah, I know. So usually I reserve that for the more difficult problems.
Okay.
If they don't respond to the initial 3 steps, then we add the night splint and therapy and some other things. Yeah.
How long can it take for one to recover from that using the therapies that you recommend? But
yeah, good question. Normally about 6 weeks for full recovery. If I do the initial shot, I see a patient back in 2 weeks. They're usually 50% better. We can do a second shot if we need to, and then by a month or 6 weeks, they're usually all set.
Can it recur?
It can, but I usually try to teach the patient some tools with the proper stretching and the supports, so that if they start to get symptoms back again, they can go back into some of those things in their toolbox and resolve it themselves. But occasionally it can be bad enough that we have to start all over. Yeah.
Oh, and why is it called sometimes the flip-flop disease? Have you ever heard that?
Well, a lot of things are flip-flop disease. Flip-flops are not very good. So,
because they're not structured enough for our feet?
Right, they're just very flexible. And so part of the cure for this is good support.
Okay.
So if you have good support, it's going to support that plantar fascia, and it helps a lot of things, yeah.
Off the record question, what about going barefoot or just wearing socks at home and never wearing shoes unless one is out of the house? Is that
well, for most people, that's just fine,
okay.
You know. But for patients who have neuropathy or diabetes with neuropathy, they don't have good feeling.
Okay.
So they need to protect their feet more. So they need some type of foot protection all the time.
Okay.
Yeah.
Well, let's talk about the medical conditions that can affect our feet.
Sure.
I'm thinking in terms of diabetes, of course. What about gout? And what about heart disease. Do those three things. Talk about that.
Yeah, those are good ones. Yeah, you've done your homework. I can
Yes.
tell.
Yes, I have.
So diabetes is the most important one for foot problems. And when a person's blood glucose gets too high, the high levels of glucose actually attach to the nerves and cause damage to the longest nerves in the body, which go to the feet. So patients develop neuropathy, and that causes several problems. The neuropathy isn't just to the nerves, which cause numbness, burning, and tingling pain, but also to the muscles and the skin. So the muscles start to get weak and there's imbalances and it causes deformities. And then the skin starts to get dry and cracked. So diabetes really has a negative effect on the feet.
Does neuropathy, what does it feel like? Does it feel like someone, do they feel numb? Do they feel tingly? Do they feel, what does it feel like? What do you hear from your patients?
You know, Heidi, the answer to that is yes, to all of those. It can feel just like a swollen feeling, a little bit numbish and swollen. Often that's the way it starts. It can be tingling, pins and needles, and it can change back and forth. Now, usually there's a progression. Usually it's kind of a mild, kind of a swollen feeling, then it gets to pins and needles, and then it goes down to a burning sensation.
Oh, how awful for the patient.
It can be really, really bad.
Does it go away, or does it stay with the life of a diabetic? Or if a diabetic is well controlled, does it go away?
Well, you know, the glucose actually damages the nerves. So if the glucose is controlled, then over time the nerves can improve.
Okay.
But they take a long time. It's like a year for a nerve to repair itself. It takes a long time. But you know, once you get into the later stages, you can usually improve the symptoms, but it's probably not going to reverse. Yeah.
My mother was a diabetic, and I remember the physician's concern often about infection and so on in her feet, and my mom literally not knowing it because she couldn't feel anything bad happening.
Yeah, it's you know, to the average person, it's really shocking to see when you might poke a needle or something sharp into your foot and the patient doesn't feel it all. It can be, it's often that bad. Yeah.
Let's talk about gout. I don't even know of any human being who's ever had it, but I know that it's still out there.
It's another thing you don't want to get, Heidi.
I will.
You don't want diabetes, you don't want gout. Well, gout is in a whole different category. It's in the arthritis category.
Oh.
Yeah. And often it's treated by a rheumatologist, an arthritis doctor, you know.
Oh, I didn't know that.
Yeah, and as we get older, our bodies may not process the breakdown of proteins like they did when we were younger. And so when proteins break down, you know, our muscles are rebuilt, and so our body's always breaking down protein and replacing it. Well, one of the byproducts is uric acid. And our kidneys usually clear that out of our system and keep it at low levels. But as we get older, in some people, your body just doesn't clear enough of it out. So it accumulates. And microscopically, uric acid are tiny little crystals. They're like tiny little sharp things. So they settle out by gravity down into the feet, and oftentimes they'll settle into this big toe joint. And
just that one
well,
joint?
It can be anywhere, but the vast majority of times it's the big toe joint. Who knows why? You know, but it can be a little toe joint or the ankle, or it can be anywhere. You know, but typically the presentation, a patient will be sleeping. They wake up in the morning, the big toe joint swollen, red, painful, feels warm. So it's like an infection, and it's usually very painful, and it's from a reaction of these crystals that have settled inside the joint.
Okay. And then how do you treat it? With medication?
Well, yes. I mean, there's two ways. The acute onset is treated one way, and then the chronic control of uric acid is treated another way.
Okay.
So as a podiatrist, I see the acute situation.
Yeah.
They come in, this is red, swollen, painful. So I get
Yeah.
an x-ray. If there's no fracture and everything looks good. Oftentimes, when they first come, I'll give them antibiotics, and I'll give them a medicine called colchicine,
Okay.
or an anti-inflammatory.
Okay.
And sometimes I'll do an injection of cortisone around that joint to calm
Okay.
down the inflammation. So generally, that'll get them started in the right direction. We get some lab work. We check their white blood cell count to see if there's infection going on, and their uric acid level to see if the uric acid level's high. So if I get a negative white blood cell, no infection, and a high uric acid, I know,
Then you
okay, I'm
know
dealing
right
with
away.
gout.
Yeah.
And then sometimes I'll wait to do that cortisone shot, and then I'll do it after I get the labs.
Okay.
But the cortisone shot and the colchicine medicine usually turn it around pretty quick. Yeah.
Let's move on to heart disease. I know that it can cause extreme swelling in the lower leg. Does it affect feet as well by swelling, or what else have
Yeah.
you seen?
Yeah, there's really two aspects of heart disease that affect the feet. The one that you're talking about is congestive heart failure. And a lot of people will get this if they've had a heart attack or some heart disease and their heart's weakened and it's not pumping well enough. Well, your body's full of blood and fluid, and your heart pumps it all around. Well, if it backs up, it accumulates in the legs. And that's when you start to get swollen ankles, swollen calves, and that's from the veins. The blood in the veins isn't coming back, and so it's pooling down there, and that stretches the tissues and can cause some significant damage to the tissues, and then wounds develop and sores, and it can be bad. Yeah.
Oh,
Now the other one is
I want to stay healthy.
the other thing that we should mention is the other side. That's the veins. Now the arteries, that's a significant problem for feet too. If a person gets coronary artery disease, that means that the arteries that bring the blood from the heart to the parts gets clogged up. Then they probably have a peripheral vascular disease also. That's where the arteries in the legs, just like your heart, they get clogged up too.
Okay.
So now the blood down to your feet is clogged up just like it would be to your heart, and now you're not getting enough
Circulation.
blood to your feet. Well, that, if you combine that with diabetes and neuropathy, now you've got a real at-risk foot. Because if they can't feel a cut on their foot or a rubbing from a corn and they get an infection, now they don't have enough blood supply to heal it. So that's where we get into our advanced wound care.
Yes.
Which is a whole fascinating science that I do a lot with that. And we have all kind of treatments like hyperbaric oxygen. We put patients in an oxygen chamber for an hour and a half a day, and they breathe 100% oxygen, and it gets it down to that toe. And these special grafts where mothers are having babies, they take the live placental tissue, and they take it, clean it, send it right to us, and there's more to it than that, but
I'm sure.
we put it's not
Few
that
more steps.
we don't just go over to the OB unit but we get those live stem cells from the placenta, and it's an amazing healing potential. So now we're losing a lot fewer patients are having amputations because of these type of problems. We're able to save a lot more feet. Yeah.
Oh, my dad died at 99, and for the last 2 years of his life, he had heart disease. His legs were very swollen, but he ended up with some of the worst wounds on his heels from lying in bed, or he'd wear slippers around the house, and they would rub. And he didn't always know that he had it. And we would go to the doctor together, and I would be flabbergasted at what was hiding inside his sock, but he didn't feel it. And that, I think, was the hardest. It's the hardest part. I would imagine you too feel like if they don't know that they have it. My God, it takes
Yeah. Oh, it does. And you know, we're used to our bodies telling us accurate information.
and you need to go to the doctor
Yeah,
now, right?
Yeah, but these poor patients, they'll have a big hole in their foot,
what he
and it's
had.
getting infected, and
Yes.
until it gets so bad that it's just crazy bad, then your body tells you, oh, okay, there's a problem. But you know, it is difficult. So Medicare has a whole thing that they cover called routine foot care. So part of what we do as foot doctors, and as I get older in the practice, I do more and more of that, and I'm handing off some of these sophisticated surgeries. But routine foot care is where we have patients in on a regular basis at these at-risk feet. We take care of the toenails, corns, and calluses, make sure they're in the right shoes, and we prevent these kind of problems.
That is a
So,
wonderful idea.
Yeah, it's
Is
good.
that available to anyone with Medicare? I mean, they would be prompted
Yeah.
probably by something hurts,
Yes.
and I want to see you.
Yes.
But then they could become a more regular patient so that
Yes.
you could prevent some of
Yes.
this from happening.
Yes.
I had
and now-
no idea.
Now, normally the criteria, normally you have to have diagnosis of diabetes or peripheral vascular disease as your underlying risk
Okay.
problem.
All right.
But generally, if you have an at-risk foot and those diagnoses, then in the vast majority of cases, you'll apply for routine foot care, and we see patients about 4 times a year.
Excellent.
just
Oh, I
kinda
wish I had known
prevent
that with
problems,
both
you know.
my parents. Really, that would
It's
have
a
been
great service, and it's fun. We get to know those
Yeah, I
patients,
bet you
and
do.
it's like almost like a family practice.
Sure,
then, you know.
I bet.
Yeah.
Let's talk about a little bit less scary stuff. Oh my goodness, we have 8 minutes left.
Okay.
But we'll
All right.
get to some of these. All
Sure.
right. I'm going to have you
Yeah.
come back
I'll
because
be
I
happy
really
to.
have a whole bunch more stuff I want to talk
Sure.
about. All right. Why do our feet get bigger as
Yeah.
we get older? They seem flatter.
Yeah.
And they seem bonier. Now, I know
Yeah.
they're not really
Yeah.
bonier, but
Yeah.
they seem like they just don't look like when I was 30.
Yeah.
What else does? But,
Yeah.
so what happens to our feet as we get older?
That's a good question. And, you know, time takes its toll on physical things. You think about your car, and, you know, you look at your tires. How many times do you change those tires? But your feet have to last the whole lifetime, you know?
That's true.
So all of the things that, you know, take stress for all of those years start to fail or get weaker or wear out. And so if you look at our picture here, you know, these tendons that hold up the arch, they weaken a little bit and they stretch over time. So the arch, you know, tends to start to flatten somewhat.
So it's not my imagination that is the case.
No, that's
Okay, it
that's
really is,
common.
huh?
Yeah, and then when your arch flattens, then your foot stretches a little bit. So often your shoe size will increase by
a half a size.
or-
That's exactly what's happened.
Yeah. Yeah.
All right.
All these ligaments, you know, they stretch a little bit too, and so your foot stretches a little bit.
So it flattens out.
Yeah.
Why does it seem like it doesn't have fat on it? Does that make sense?
Yeah, it does. And there's an atrophy of, you have these fatty cushions, especially into the ball of your foot and the heel.
Right.
And those fatty cushions are amazing structures that God designed to provide cushion, you know, for a lifetime. But after a while, they start to wear thin. And so now there's not as much cushion under the ball of your feet, and so people start to get calluses.
Yes.
Yeah.
Yes. That is See, I am
Yeah.
getting older. This is my feet are telling me this too. So, all right, let's talk about calluses. Are they bad? Do we just live with them? I know of people who have them on their heels because they're
Yeah.
runners.
Yeah. Yeah.
I'm starting to get them under the ball of my
Yeah.
foot for
Yeah.
no reason whatsoever.
Yeah.
So, are they bad things? Are they good
Well,
things? Or do
you know,
when do we worry?
You know, your body's trying to protect you, you know. And so if this fatty cushion starts to wear out, Now the cushion's not there, so the skin has to try to protect from the forces, the ground forces. Well, your skin only has one solution for everything, and that's to make more skin. So it can't put the cushion back, so it starts to build more skin cells, and that makes a callus. Well, and that works for a while, but as the callus gets thicker and thicker, now it's causing more pressure on the bone, and eventually it starts to hurt or cause pain. So normally in a patient with no neuropathy and healthy circulation,
right,
trimming the callus or using a cushioned insole is usually adequate.
All right.
That's usually adequate. But in a diabetic patient with neuropathy, they're not going to feel when it gets too thick.
No.
And this is where we get into trouble. They break down and get a sore, and then an infection,
right,
and that's where we get into all the
good Lord.
the trouble.
Right at the bottom of their foot.
Yeah, so that's where the routine foot care is very helpful. They come in and we trim the calluses, corns, toenails, and just protect people, yeah.
I seriously mean this. I would love to have you come back.
Sure.
Because there's this whole middle section here that I want to talk about. Like bunions and hammer toes and all of these weird things.
Yes.
I shouldn't call them weird, but I don't mean it in a derogatory way. It's just that I've seen them in my sister as she gets older and my best friend, and it seems like everybody's feet start getting all goofy looking.
Yeah, they do.
So I really do want to talk about that, but we'll have to do that in the next time you're here.
Okay.
What I'd like you to do now is, as a healthy 68-year-old, I walk, I am fine, my feet don't necessarily hurt all the time. They hurt sometimes, but what should I be doing routinely to keep myself and my feet healthy?
Well, that's a great question. So you want to prevent some of these things.
Right.
And actually my answer may not seem very direct, but probably the best thing you can do is to keep your BMI, your ideal body weight, within the normal ranges. Because if your body weight's within the normal range, you can talk to your family doctor. They have a chart of what your body weight.
Oh God, yes, every
and
6 months.
They're aggressive.
Yes.
I mean, it's usually a lot less than you want to be.
Yes.
But the closer you are to that BMI, the less likely you're going to have diabetes. And if patients don't have diabetes, they have dramatically fewer foot problems.
Okay.
And also it decreases the risk of cancer and other problems that put the extra weight puts lots of stress on your foot. So we're going to avoid stress fractures and a lot of issues. So keeping your body weight as ideal as possible is going to be your best bet at having healthy feet.
Okay.
Yeah. Now, in addition to that, you want to be proactive. If you start to see deformities forming like a bunion or hammer toe, then you want to see a podiatrist early on to check that out. Sometimes with an orthotic, we can make a device that controls. It's like glasses. If your vision's bad, you get glasses. If your arch isn't functioning properly, sometimes we can build an orthotic to kind of make your foot function better, and that controls the biomechanics, and you won't have these deformities as much down the road. So that's a proactive thing you can do. Yeah.
All right. So just be aware of keeping our feet as healthy as possible, keeping our weight down, staying as healthy as possible. Mm-hmm. And once things start hurting, more than just, oh, shoot, my feet hurt today, see a podiatrist.
Yes. Yeah, because there's a number of things we can prevent from getting worse.
Okay.
Also toenail problems. If you start to see yellow, crumbly material forming, that's fungus. And, I have a lot of patients who are in their 80s and 90s where it's just kind of completely taken over. But if we catch it earlier, we can prevent that and turn that back around. And ingrown toenails, that's usually inherited, but if you start to get pain, they get worse as you get older. So if you start to get a painful ingrown toenail, there's actually a little root canal procedure we can do and fix that permanently, So
No
that when
kidding.
so when you get down into your 80s and 90s, now it's dangerous because your circulation may not be
Right,
good and you have an
right.
infection. But if we fix that when in your 50s or 60s or even 70s, if you're healthy, we can permanently fix that ingrown toenail, and then then you don't have the problem later on.
And you said that's inherited.
Yeah.
So the tendency towards ingrown
Yes.
because of the shape
Yes.
of the. No kidding.
Yeah.
Oh
I
my
wouldn't
gosh.
kid you, Heidi. About
that is that's interesting. I didn't know that. I have seen in my sister exactly my mother's feet, and thank God I inherited my father's feet,
Yeah.
so I don't have those issues.
Yeah.
But she's had
Yeah.
one thing
Yeah.
after another, and so did my mother
Yeah.
all the time I was growing up.
Yep.
So. All right, Dr. Rasper, I would love to have you come back.
Very good.
And I want to talk then about less scary things,
Okay.
but still things that can bug us.
Gotcha.
Will you do so?
I will.
All right, this
I will.
spring. Thank
Okay,
you.
let's
Thank
do
you
it.
so much.
You're welcome.
And I hope you have enjoyed this episode of North of 60. Dr. Rasper's office information will be at the very end of the show, and you can call for an appointment at the local Hudson office. Thank you so much for watching.